So I'm coming from Madison, where we have a new psychedelic research center that I'm privileged to be the director of. And I wanted to talk today about some of the work that we're doing and some of the things that we need to be anticipating as we look at this area of psychedelics. Now, let's start with taking a look at a motor grader. Now, let's assume that these ruts that you see in that road are negative thoughts, negative thought patterns, difficult to get out of. And we would like to use that motor grader to smooth out that road and be able to have a more consistent, positive set of thoughts, whether it be in context of depression, substance use disorders, PTSD. So let's smooth that road, get out of those ruts. Now, I don't know how many people in this room would feel comfortable stepping into the cab of that motor grader and taking charge and smoothing out that road, but perhaps you would, okay? It's a nice flat field. But what if the circumstances were more life-threatening? Okay, maybe this is a much more severe case of depression, something more severe in terms of substance use disorders. So are you going to be trusting yourself to be able to fix that yourself, or are you going to need some mentorship? So we'll put a pin in that for now. Okay. Let's talk a little bit about psychedelics. We have a bullseye chart or target chart here put together by Josh Hardman from Psychedelic Alpha. And what we see here is a sense of how close drugs are to being FDA approved. And you'll see that in the center, the pink spot has only one drug in it. That's the esketamine nasal spray that is used for depression. But the closer you get to that pink spot, the closer you are to FDA approval. And you'll see in that darker blue that there are about 6 drugs with FDA breakthrough status that are in phase 3 testing, very close to being approved by the FDA. And I would argue that in the next 2 years, maybe even one, we're going to have one or more psychedelics approved by the FDA for depression, most likely, and PTSD. We see here the different drugs that are being looked at. Psilocybin from mushrooms is one of the ones that's most familiar to many people, but we also have 5-methoxy-DMT at the very top, which is the exudate of the Sonoran Desert toad. That's where the expression licking the toad comes from. I'm not sure how many of you have licked a toad before, but if you're going to do it, you'd probably want to get the Sonoran toad to have any benefit at all from it. We also have LSD down there in the lower right. DMT at the lower part of the curve is from ayahuasca. This is the active ingredient there. And we also have ketamine, ibogaine, and MDMA, also known as ecstasy or Molly. That is one of the drugs that is very close to being approved for PTSD. And I'll move to a different chart here that shows what these different drugs are being used for. You see PTSD, lower left, and depressive disorders being the predominant one, but we also have anxiety, substance use disorders, and then a small portion of others, such as obsessive compulsive disorder and such. So I'll start with depression. Depression has been the most heavily studied. Typically, the companies that are looking at it are looking at the effect of one dose, one very strong psychedelic dose. And not everybody responds, but for those people that do, the effect can be dramatic. Even in the course of 24 hours, the depressive symptoms can be gone. And yet we don't really know how long those persist. We don't know how long they're going to be able to benefit from that single dose. And we also don't know exactly what the dose should be. We know that the dose should be fairly strong, that with a psychedelic hallucinogenic experience, but we don't know how much higher we might be able to push that, how important that psychedelic experience is. We don't know how durable this is. In some cases, we see people benefiting from that one dose for 6 months, in some cases even longer. What would happen if we gave booster doses? We haven't really tried that yet because the companies feel like they can get FDA approval with one dose of a drug. We also have other questions. In addition to multiple doses, booster doses, can we give therapy to more than one person at a time, just to make it more efficient of their resources? Do we need to taper off the other antidepressants that they have been taking? In the past, we have said, yes, we do, because it seems to mute some of the psychedelic effect, but we really don't know if we need to do that. Is the psychedelic effect really critical, or is it just kind of a side effect of everything else that's happening? We don't really know yet. We have a lot of psychotherapy that goes into it. I'm going to talk a little bit about that, but we don't really know yet what the level of that psychotherapy should be. And we have a efficiency of qualified mental health practitioners in the country now. And if we're going to be using more of them for these psychedelic dosing sessions, we're going to have to figure out how to make those people available to us. Wanted to talk a little bit about psychedelics of addictions. This is one of the areas where we're quite strong up in Madison. And I'll start with tobacco. In a pilot study of 15 subjects with 6 failed attempts to stop smoking in order to get into the study, Johns Hopkins University showed that 80% of the subjects in this study were abstinent, no smoking whatsoever at 6 months. And that was with no gum, no patches, cold turkey, with some behavioral therapy, some other counseling. But after 3 doses, 80% abstinence and 60% at 1 year. Now they're doing a multi-institutional study, a follow-up study now to test that, but these are really exciting results, much better than the other results that we've got with other drugs that we've got available to us. Then what about alcohol? My image is not coming up. Okay, so alcohol. If you compare psilocybin versus a placebo, the psilocybin group had at least a twice as likely abstinence rate at 33 weeks than placebo. Okay, twice as good. But what was really interesting is that in the last month of those 33 weeks, it actually improved more so than it had in the earlier part. So something is happening into these individuals that is enabling them to stop drinking and to have at least a 25% likelihood of abstinence. There we go. Okay, so you can see this. And then some of our own work with methamphetamine. We've got 3 subjects that we were able to study so far with the money that we had available. And we saw a greater than 90% drop in the methamphetamine use of these individuals that got 2 doses of psilocybin. Okay, so something is happening with these individuals that is allowing them to get, after 2 doses, almost completely off the methamphetamine. In some cases, completely off. A lot of people are interested in microdosing. There's actually a fair amount of work that's been looked at with psilocybin or LSD. And in fact, you can show that cognitive functioning, memory, and other measures of cognition actually improve with microdosing, chronic microdoses. However, it also occurs with placebo. And so that's a problem. And in fact, even more of a problem is the fact that in many of these studies, the placebo group actually did better. So at this point, there's no real benefit obvious of using microdosing. And there's also a concern that we've got, at least in mouse models, that chronic dosing with these psychedelics actually leads to some very serious heart problems, which is why my little friend here is clutching at his chest. We haven't done these studies in humans yet, but if we're going to look at chronic dosing of psychedelics, this is one of the big questions we need to answer. But at this point, chronic microdosing is not a good idea. Okay, so back to the question, how do psychedelics work? We really don't know. We really don't know. We don't know if this magical, swirly, psychedelic, hallucinogenic experience is critical to the experience, or if it's just kind of a side effect that we see in individuals who have a dose high enough to have some therapeutic impact. But we also seem to have some really strong evidence certainly in animal models where we can actually, for the mice, but we can actually look at the brains of mice before and after they've received psychedelics. And what we're seeing is that there is an increased neuroplasticity, more dendrites, more synapses being formed after a dose of the psychedelics. Not chronic dosing, just a large dose of the psychedelics. And so you can see more connections here being formed between these neurons in the brain. Not new neurons, more connections. So what does that mean? But we go back to our motor grader, trying to get rid of these ruts. We have a brain of individuals with an addiction, or who have an obsessive compulsive disorder, or who have embedded thoughts of depression that is not allowing itself to really move out of these ruts in the brain. And you see that characterized by these lines in the brain here. Those correspond to the ruts that this motor grader is trying to smooth out. Okay. Now, what these increased numbers of dendrites and synapses seem to suggest, we see this in both EEGs and also fMRIs, various forms of magnetic resonance imaging, is that the brain is actually able to communicate with more parts of itself than it normally allowed itself before. And so new thought patterns, getting out of these ruts, seems to be characteristic of these larger doses of psychedelics. And yet, if you're going to rewire your brain, you want to do it by yourself. If you're managing the switchboard where you're going to try to make all these new connections, you feel comfortable stepping up to the switchboard and making these selections yourself. This is a problem. You'll recall that in the 1950s and 60s, there was the MK Ultra program of dosing people with LSD by the CIA, trying to get it to use as sort of a truth drug or to modify behavior. So there are some negative potentials for individuals who are in this plastic state after a dose of psychedelics. And we're concerned about that. How do we do this in a way that is safe so that we can have a smooth road in a patient who's got some critical mental illnesses that we need to take care of? And so one of the ways that we do that is what we call setting, and support. This is the dosing room at the School of Pharmacy up in Madison. And you can see that it's got the nice sofa where the person can lie down if they like, eye shades, music. And then you've got the two chairs there with the therapists that are there to reassure, to help them with their intention setting, and to provide some guidance during the session, even more so with the PTSD doses with MDMA. We feel that this preparation, the setting, which is a nice, safe environment that you're not going to run out of into the cold and hurt yourself, and then the support, the reinforcement of that experience in days, weeks afterwards is critical. And that's what is making this so very expensive, quite honestly. So if you look at the drug, it's really quite easy to make. I don't want you to go out and try to make it. There's some steps that are hard, but it's very easy to make. So it's not really that's the dose limiting factor or the rate limiting factor to be able to dose people. It's these access to the therapists, access to the room. If I'm using a room for a day, plus the prep and the debrief sessions, I can only dose 2, maybe 3 people in a week in this room. And with thousands of individuals clamoring for treatment for PTSD by the VA, depression, substance use disorder, we're going to need to figure out a way to be more efficient. We also have the time of all these other things that come to bear in terms of the process of a single dose. We also have to screen people to make sure that they don't have a psychiatric illness that we might make worse with a psychedelic experience. However, I want to say that the future looks quite bright for psychedelics. I think that there is a lot of opportunity for us to explore more efficient ways to do this, and we're looking at this in Madison and other places as well. We have in the next 2 years, as I mentioned, the likelihood that we're going to have MDMA for PTSD and psilocybin for depression. Now, once we have that approved, typically we have all these other black boxes or other opportunities for off-label prescribing of these drugs. So the psilocybin we could use for substance use disorder. We could use it for obsessive compulsive disorder. But the question is, are the insurance companies going to pay for that? And are they going to be willing to pay not just for the drug, but for all the time of the clinicians that is going into preparing the subject, sitting with them over that dosing session, and then afterwards debriefing them and reinforcing them. At the current time, the FDA is requiring that the 2 people in the dosing room that are providing therapy or at least monitoring it, at least one of them has to be a credentialed healthcare professional, and the other person has to have a year of mental health experience. And those people are hard to find now. And if we put them in a room for 8 hours a day, it's going to be difficult to get other people the mental health care that they need, grappling with that. We have also these psychedelics. They're focusing on increased neuroplasticity. I mentioned the evidence that the psychedelics will increase the number of synapses that can be formed, that there is actually the potential for healing, if you will, of damaged neurons. And we're looking at drugs that are able to do that without causing the psychedelic experience. Our hope is, and of course, some of the companies that are developing this, our hope is that if we don't have this shock and awe psychedelic experience that requires somebody to be in a room safely watched by others and reassured if they get really scared by the experience they're having. If we can have that neuroplasticity, can we make this a drug that we can give somebody to take it home in their own safe environment and then reinforce in a more traditional, come see me, we'll have an hour-long chat in the subsequent weeks, making it a little bit more possible. We don't know the answers to these questions yet. We don't know what kind of formality that we need in terms of the different drugs that I pointed out. Do we use the same sort of set and setting for MDMA as we do with psilocybin, as we do with LSD? Do we use the same sort of counseling, preps, and intention setting for somebody in the Black culture as somebody from the white culture, Native Americans? Do we treat everybody the same in this whole process of psychedelic care? We don't have enough people from minority groups to really know, but that's one of the other things that we're quite concerned about. And I think that one of the things that I'll really point out is that although I'm pointing out some concerns that we've got, we're really excited about the role of psychedelics as a new tool for psychiatric care. But I want to really emphasize that it's not a take this home, let me know how you feel tomorrow sort of drug. We're talking about psilocybin or psychedelic-assisted therapy, where we really need to have individuals who have the training, the background to care for these individuals augmented by these drugs. But it's an extremely exciting time. Stay tuned. This talk is going to be outdated in about 6 months. So watch it while you can, because it's going to be outdated with all the new exciting things that are happening. Thank you for coming.